Hi, everyone. Thank you for joining the webinar tonight. Tonight's webinar educational grant is supported by Virtual Field. I'm Dr. Maria Sampoulos, the webinar host for tonight, and our guest speaker is Dr. Jessica Steen. She's an associate professor at Nova Southeastern University and also director of glaucoma services at the Eye Care Institute at Nova. So thank you, Jessica, for coming on tonight and giving us this lecture on AI-enabled glaucoma management. So I'm going to hand it over to you. And Dr. Steen said you can ask the questions as you go through the lecture. She will try to answer them. And we'll also have a question section at the end. So thank you so much, Dr. Steen, for doing this lecture tonight.
Maria, thank you. Wonderful to join you tonight, and thank you for joining. Again, this week back always feels like there is a lot that starts. Kids are back in school, so thank you for making the time to join us tonight. As Maria let you know, I'm Jessica Steen. I'm in South Florida, where it is a brisk 49 degrees outside. I'm originally from Midwestern Canada, so when we talk about weather change and you see the people in South Florida today wearing their ski jackets and gloves. It takes everything in me not to truly smile and laugh at the discrepancy, the difference, the perception of what winter truly is. So tonight we're talking about AI enabled glaucoma management. One of our real crowning features at the university, at Nova Southeastern University, is this new center of innovation. We think about how our practices have changed in the last 5 years, how our university campuses have changed in the last 5 years. And this particular feature at Nova, this is not an optometry component of our college, but of our university as a whole. And really, the goal of this center of innovation is to connect students, to connect faculty members with private industry within finance, within robotics, within pharmaceuticals, within medicine as a whole, to really develop these types of think tanks that drive our profession, our world, our environment forward. So, as we think about how artificial intelligence and how deep learning impacts us day to day in real life and is growing within our practices, we're really going to hone in and focus on the management of glaucoma, really an area, of course, clinically near and dear, and really from a research perspective, where my core focus is. My financial disclosures are here for you. What is most important is that any and all relevant relationships have been carefully mitigated. As Maria mentioned, I've got the chat box up, I've got the questions box up. Anything that comes up through this discussion, please bring it forward. I am more than happy to discuss. So you think about it, we're at home, look at your wrists. Who's wearing an Apple Watch right now? You think about what we use, the tools, the technologies, what apps are on your phone to track metrics. I've got a pulse monitor on my phone, one of these neat tools that, maybe we don't use that frequently, but we have available to us. We think about the home based technologies that we have to provide to some of our patients, whether that's something to potentially monitor intraocular pressure in certain patients in a home based setting, or currently thinking about the new home based OCT that exists for a subset of patients. Think about in your office, what virtual reality based devices are you currently using? Or which are the ones that you're thinking, or maybe you just purchased late 2024, or you're thinking about adding to the practice in 2025. Or for those of you who have added virtual reality based devices like visual fields, what's the feedback been from your patients? How has that changed, or how has it even changed the way that you think about practicing optometry and managing glaucoma? And then we really think about the artificial intelligence based devices, which we certainly pair and see being paired with these virtual reality based technologies, medical apps, and home based technologies as well. Now, we do certainly have FDA approved AI enabled technologies even in the eye care space. And when we put this all together, where this sets the stage to really advance healthcare and looking ahead is to expand the timeliness, the availability, and the accuracy of diagnostics and of diagnoses and of the treatments that we provide for patients. So, why are we talking about this so much this year in eye care? Maria and I were just chatting offline about the new publication that we have about AI in eye care, a, a true standalone publication on this topic. So, why is there so much interest in eye care specifically? What's the drive? Well, think about our track record as optometrists. We truly, as a profession, embrace technology and actually utilize it. The tools that you purchase, that you gather, you use in a clinical environment. Our patients truly do rely on us and see that as a real bright star. We think about primary care medicine. Is it that same level of technology? We only hope, we only wish. We really think about what we do and how our patients really reach out to us as a resource that fits a comprehensive eye exam once a year. They're interested to know, hey, doc, what's new in the practice? And we're happy to show them and share with them our new tools and tech. We're truly proud of that as part of our profession and the services that we provide. We can also certainly think about the improved access to technologies for traditionally underserved or truly unserved populations in the United States, as well as locations outside of the United States. And we've certainly all seen handheld or even smartphone based cameras and adapters and software, as well as in office technology. So, when we think about this in eye care, we can really take this through four levels that are all being addressed, all being thought about within the context of disease states that are truly responsible for global vision loss. Diabetic retinopathy is number one, macular degeneration, and of course, glaucoma, and they're very different. We're really going to focus primarily here, of course, on glaucoma, but we are going to use diabetic retinopathy as an important example to really see how diabetic retinopathy detection using currently available AI devices and what we do in a clinical environment is very different, and how glaucoma, as new technologies are being developed to aid in diagnosis and management of glaucoma, are really very different from those devices for the detection of diabetic retinopathy. So we can take it from the top and think about screening. How can we find people in the community that may be at greatest risk to bring them into our practice sooner? How can tools aid in the diagnosis of disease? And once a diagnosis is made, if we think about glaucoma specifically, what is every subsequent visit utilized for? We know the patient has disease. Now we're trying to find that tipping point to identify if and when progression happens. And then longer term, this is truly the holy grail in medicine, is prediction. That can be thinking about this in two different ways. Either what is that patient's overall risk for development of disease? Can we predict if or when a patient may develop a disease process? Can we develop if or when a patient may change or progress? And how can we predict the effect of a specific medication on a particular patient? This is something that right now, that's actually really very interesting to me. So let's think about management of glaucoma. All right, the tools that we utilize, we're not just thinking about a patient in an isolated exam state, a one-shot deal. We are watching and managing patients over their lifetime. That might be 10 years from diagnosis, that might be 5 years from diagnosis, or that might be 30, 40, 50 years following the day that you diagnose a patient with primary open-angle glaucoma. So we're utilizing data that you gather both on an individual visit that you evaluate that patient following the diagnosis, and we're also comparing that patient to their past visits. What has their trend been? Is there a downward trend related to progression, or like this visual field, and as an example, really very stable over this 5-year period? This patient is really doing very well versus the OCT change that we see in the top left corner. We're also evaluating the patient clinically. Of course, bottom left, we've got a new optic disc hemorrhage. How does that impact our management? And then we think about other tools, other techniques, other brands of devices. Maybe you upgrade your piece of technology and you move from one brand to another. Now we've got past data, present data, and the long-term 10 years of data with this particular patient. When we really think about the onus and the amount of data that we as optometrists evaluate in an isolated clinical visit for a patient with an established diagnosis of glaucoma, this is just the ancillary imaging. Never mind the changes to medical history, never mind the comorbidities that this patient has, the new dry eye disease, the new development of age-related macular degeneration, the intolerance or allergy to medication. Honestly, sometimes I really don't think we give ourselves enough credit for the amount of work that we do in the background before we walk into the room, clinically examine the patient, talk about the findings and what happens next. So we are gathering more and more parameters, more and more data points. We think about the new tools that we're being exposed to, that the new tech that you may apply to your practice. We've got a billing code for OCTA. That's not a replacement for any other piece of technology. This is an add-on. So as we're gathering more and more points that we're evaluating, interpreting, and actually applying to the patient's data and their case as a whole, this is more work for us and more areas that take time, that are potentially prone to error or misjudgment. And, then you really think about the patients that we saw today. And, if I'm thinking about the individual glaucoma patients and interpreting data, how many times did I repeat that finding or enter a data point in one system or one place in the patient's chart just to apply that finding again in the assessment and as part of the patient's plan? We think about the redundancy in our documentation. And really, when you break it down and think about it, that means that there's a lot of room for streamlining this data entry, data interpretation, and potentially the development of new data points that are more holistic, that can be important markers in watching patients over time. We can think about it another way, and let's talk about, this new referral. You've examined the patient, or you've been newly referred a patient who is suspicious of glaucoma. When we talk about what a glaucoma workup is, what is that? What does it include? Is it a set of tests on the exact with every patient? Or is it a true individualized approach? Certainly what we evaluate and what we aim for is a truly individualized approach, which means that there's no such thing as a standardized glaucoma workup. It really does depend on the patient, their individual clinical features, and what had them ultimately labeled as a glaucoma suspect to begin with. Is this related to strong family history? Is this related to elevated intraocular pressure, ocular hypertension? Is this related to a narrow anterior chamber angle that requires further evaluation? For each one of those patients, depending on their overall risk profile, what we do on that first day to evaluate risk is going to differ. We can't do everything on the same day. So how do we pick, choose, and really rank and understand which pieces of data may be most valuable on that first visit to drive our clinical decision-making process? It really does look different for different cases. And this is something that, once again, comes back to us as that challenge in how do we provide that true highest level individualized care. Now, let's look at OCT. So we all utilize reference databases. All of our OCT devices incorporate them. And we think about these reference databases, and this is kind of the opposite of individualized evaluation. What these reference databases are made up of a group of healthy individuals that our patient that we're imaging is being compared to. Now, this is something that when you think about the number of individuals that are included in these reference databases, of course, it depends on the device, but we're looking at overall a very small number of individuals that make up a subset. Something that we're going to talk about a little bit later is that if you also think about this, which goes for any clinical trial, who are the patients that are going to be most likely included in a clinical trial or a reference database? These are patients with access to care to begin with. These are patients that present to a center that is part or that is running a study, often large academic centers. This means that this is already a subset of patients that does not represent our entire population. So we really do have to think about the limitations of reference databases. So when we're comparing the patient in our office to this group of normal individuals that were included in the reference database, we really do have to think about if our patient fits that standard mold. And it really does differ from the individualized approach. And that's where these errors, these red disease and green disease errors come into play, not because the imaging technologies or tools are behind or require adaptation or new development. Our tools are exceptional. It's just the way that we interpret and evaluate the information can sometimes be misleading with reference databases. So we really do have to think about how our patient fits that mold. Let's look at some patients who certainly don't fit the mold that can be challenging. This is a young individual, East Asian individual in her early 20s, normal intraocular pressure. She is myopic, as you might expect, based on the optic disc appearance and that stretching of the vasculature temporally. As axial elongation happens, this is again stretching of the sclera, stretching of the retinal vasculature and retinal tissue along with it. This is an individual that is over that 8 diopters of myopia. This patient would not have qualified for any of the reference databases to be included in. She's young, she's healthy, she has beautiful retinal nerve fiber layer. But when we look at the imaging overall, we do see that we've got this typical, pattern that we'd like to see, this butterfly wing type pattern, symmetric, inferior, superior, left eye to right eye, but the peaks of the Tisnet plot are stretched temporally and not found where the device expects them to. This, when we look at the quadrant and clock hour analysis, gives us these red areas. We look at the overall printout. We've got a lot of red that's here. Is this abnormal? This is a perfectly healthy individual. When we've got anomalous optic discs, sometimes the ganglion cell complex can be helpful. This is one example where I find this patient's ganglion cell complex, as it is normal, to be helpful. So why do we have those little kind of reddish rings around the outside of the measurement of the ganglion cell interplexiform layer? Think about this again in highly myopic individuals being common as there is a magnification difference. There is overall this minification of the ganglion cell complex in imaging because of her high myopia. So that area is overall slightly minified in the device. Normal eye, healthy individual doesn't fit the mold. We can think about somebody with end stage or very advanced glaucoma. These are not pale nerves on the right side. This is just sclera. The left side inferior temporal, there is just a small amount of rim tissue that's remaining. This is a patient that is below that floor with where further disease progression happens. The OCT, retinal nerve fiber layer, and ganglion cell complex have bottomed out. They will not change further. So how do we monitor this patient? Well, objectively can be challenging. OCTA has certainly been proposed and we are utilizing in patients, especially with advanced disease, as there is not that same floor with OCT angiography. Depending on the device that you use or that you may consider using, there are different parameters, different, again, database density plots that can be included. And really the thought is that the OCTA of the parapapillary region lines up very well with retinal nerve fiber layer analysis, and OCTA of the macular region really agrees well with our ganglion cell complex analyses. Now, how about this highly myopic individual? These large areas of parapapillary atrophy really do make it difficult, in this very shallow optic cup, really do make it difficult to assess the optic disc structure. And certainly in this patient's case, this is a much more difficult eye to image using OCT. And segmentation error is, the challenge that the device has in picking up the landmarks of Bruch's membrane opening to identify the outer margin of the optic disc and to help us to provide these true parameters. We mentioned that sometimes the ganglion cell complex analysis in high myopes can be helpful. Here, I'd actually say on the left eye, this is fairly helpful. In the right eye, maybe as well. If I go back for just a moment, look at this focal little punched out area. This is myopic maculopathy that's starting to develop. Now, if we look at our ganglion cell complex analysis, that inferior area, that of atrophy, aligns very well with that focal thinning. So actually, in this case, even though the ganglion cell complex is far from perfect, I do think that there is valuable information that's here. So let's bring this back to where we're going. We think about what a model is designed to do. Now we're talking about artificial intelligence models. There has to be an input. There has to be the model itself, these inner layers of analysis, and the output. Now, if we think about this, and really we're going to hit with the low-hanging fruit of diabetic retinopathy, if we ask the question, is diabetic retinopathy present? Yes or no? That's ultimately what we want the output to be, and that's what the inner layers of the model itself is designed to distinguish. It will be trained on features of diabetic retinopathy detectable in fundus photographs, and that's what the goal of the model is. The input, a fundus photograph. So if we look at this particular case, what goes in? Standard fundus photograph. The work that is done on the inside is to determine, does this image have features that are consistent with diabetic retinopathy based on how this model was trained in typically tens of thousands, sometimes hundreds of thousands of images and evaluated for accuracy. Now, that doesn't always mean that the model utilizes the same markers that we do in a clinical setting. We think about, what is diabetic retinopathy? Microaneurysms, intraretinal hemorrhages, cotton wool spots, areas of exudate, if we're talking about diabetic maculopathy in particular, neovascularization, new fibrotic tissue. We can think about all of these pieces, and that may be what a model relies on, but more likely, think about it this way, that it's a much more pixelated, broken down feature, that it might not actually be utilizing some of the same features or clinical features that we think about. But this is where the explainability of a model is important. It's important to understand how the model comes up with its output, and that's often one of the challenges in FDA approval or authorization of a tool, and something that can be challenging to do. How do we explain how this technology works? Now, this is a fairly straightforward question. If we think about it clinically, how many of us saw diabetic retinopathy today? This is a straightforward clinical question. Is retinopathy present, yes or no? If we think about a very straightforward glaucomatous optic neuropathy case, this is actually a straightforward clinical question for us as well. We don't need this patient's intraocular pressure, their age, their background, their central corneal thickness. We can look at this clear notch in the inferior neuroretinal rim, this large retinal nerve fiber layer defect. Nothing notches a nerve like glaucoma, as my mentor has said. This is true disease. Now, this is where it gets a little trickier. This patient has cataract. Well, maybe that superior rim's a little thin. Well, maybe the inferior rim is too. Does this patient have disease? We think about clinically, we would evaluate this patient further. This is a tougher question for us to answer based on an image alone, and for any model to answer based on an image alone. And where it gets really tough are the nerves, and again, the cases that are really tough for us clinically. This highly myopic eye, this true scleral stretch, this is challenging for us as it is for a model. Now, one thing to highlight here is that each of these cases that we've discussed are truly task specific. What is the one question we want the model to answer? What's the output we're looking for? Now, if we think about this and we look at these 6 cases, all right, if we're asking this model to detect or determine the presence of diabetic retinopathy, that's the only thing that it can do. This is very different from what we do clinically when we holistically evaluate the ocular health of a patient and the patient's entire picture. Top left corner, this is a healthy optic nerve, healthy individual, no diabetic retinopathy. Top center, this is proliferative disease. Models are truly very good at detecting diabetic retinopathy. I would expect that this would accurately be detected by a model designed to determine presence or absence of diabetic retinopathy. Top right, This woman doesn't have diabetic retinopathy, but she absolutely has glaucomatous optic neuropathy. This is where the challenge starts with the currently available models that are being utilized. Does this patient have disease? Think about this patient being screened at, your local drugstore with the current existing cameras that we know we have across the country. Would this patient be screened out to have follow-up with an eye care provider, hopefully an optometrist, which we also know is not usually the case? No, this patient does not have diabetic retinopathy. If that's what the device is designed to do, this patient doesn't have it. She has sight-threatening glaucoma. This would go unchecked by a current model determined to detect the presence or absence of diabetic retinopathy. Bottom left, well, this isn't diabetic retinopathy, but it is diffuse drusen. In the center, this is actually proliferative diabetic retinopathy with attractional detachment. I wonder if a model would detect this as diabetic retinopathy or not. It is a much more challenging case. And in the bottom right corner, well, we've got hemorrhage, we've got ischemia, but this isn't diabetic retinopathy. This is truly an ischemic central retinal vein occlusion. So keep in mind that these single tasking models, really, they provide some value, but certainly not the value that we hope or that we provide. Now, let's look at who's really involved. The key stakeholders in development of new models. Number one, we have to think about ourselves. What do we need? What are we looking for? Why are we interested in new technologies? We've got huge additional burden related to coding, related to billing, related to workflow. We would love to have decision-making support tools. Now, I say decision-making, not diagnostic tools. Diagnostics is very different versus decision-making support. Diagnostics means that the device tells us what the patient has versus suggesting or helping us to maybe provide a differential diagnosis. Remember, we provide the final say. Who is responsible for the patient? No model is responsible for the patient under your good care. You are ultimately responsible. We can also think about development of reports. How wonderful would it be to have help with tagging or flagging on an OCT or visual field to help to automatically populate our overall report, or even a high quality summary report based on not just our clinical documentation, but our ancillary testing as well, and maybe that patient's past history to bring that into the relevant physician. And patients are interested. Now, patients, of course, they want safety as number one and reliability. And that really reliability speaks to safety. So let's look at some of the tools that exist that are being applied and are being thought about within eye care. They're not trained for eye care and they're not specific for eye care. But of course, our commercial systems, ChatGPT 4.0, really quite remarkable with the tools that exist as a large language model that really do focus on language itself. Gemini, Grok, and the open source systems like Llama 3, like Falcon, those that are currently being developed. These are multimodal large language models. They do focus on language. That's where they started, but voice, but images, this has come into play to really strengthen the models. Video, of course. Now, how these models, once they're rolled out, how these models continue to improve upon themselves is with reinforcement learning with outside human feedback. So you think about this and think about maybe a chat bot that comes up that you've got a question. Costco, your first option is to enter your question into the chat before you get connected with any individual. This is commonplace now. We're much more used to it. May not still love it, but the chatbots have improved. Why is that? Number one, they were trained initially on some good quality data and certainly some low quality data. And this is always optimized by feedback. Are you satisfied with the service that you were provided? How did I do? These types of questions, that basic thumbs up, thumbs down, that reinforces what the model's doing well and what the model's not doing so well. And keep in mind that prompt use is the core. Certainly, we all know that there are classes based on prompt use, based on classes designed to improve prompt utilization. And I think about this and say, what these classes are really trying to change or trying to train is critical thinking and curiosity. If you ask the right question, you're going to get the answer that you really want. This is what we do clinically. We can ask our patient a generic open-ended question, and we're probably going to get a long-winded open-ended answer that really didn't hit up what we're trying. But if we ask a question in a specific, curious, particular way, we very well may get that exact response or answer that we're thinking about or that we're trying to elicit. So honestly, my personal take on a university or college level course on prompt utilization, let's just talk about communication and psychology, really interacting with individuals. We can get that same data, we can get that same information. Now, the models that exist are not specialized for eye care, and maybe they need to be. There have been certainly some gaps, some errors in the eye care space, in medicine, in other fields, where these more generic or open-ended, true large models that can do seemingly almost anything may certainly have errors involved. And, one of the ways that we can potentially reduce some of these, what we call hallucinations, or these errors, this illogical, wrong data that sounds like it should be correct until you really dig into it, is something called retrieval automated generation, to ground the model on an external source. Have that backboard of a truly understood, validated data. Maybe, something, this is a very small example, it would be multiple examples of this, but have the model grounded based on the most recent version of Kansky, an understood, well evaluated, well validated background source that, the model may spit something out, but it's fact checked against this standardized source to try to reduce some of these anomalous or just flat out incorrect answers or responses. When we really dig into what is most current, we're talking about foundation models. Now, foundation models can be these large language models. They do have overlapping features and are often talked about interchangeably. Foundation models are really at the top of the top. These include language, vision, speech, video, audio, and we're talking large, hundreds of millions to billions of data points. This is unlabeled data that train and learn and develop through a true self-supervised approach, and certainly can be multitasking models. Not just asking, is diabetic retinopathy present, yes or no, but potentially feeding data as a whole. And that could be background data, that patient's electronic health record data, and already starting to develop an understanding or a risk stratification for that patient. There are other applications, there are other possibilities that exist. When we think about what we need clinically, help to organize our data. This can be patient workflow, this can be check-in data, insurance data, optical data, helping us to summarize data, whether that is something like interpreting overall. I'd appreciate one more thing, just if everyone can mute for just a moment. Thank you.
I am Bagheera.
Hi, Bagheera. What can I help you with?
So I'm sorry, I don't know why there's a background. Everyone's on listen only, so I'm sorry.
All
I don't know
good.
why that
We can
was.
talk about summarization of data. We can talk about clinical decision support tools. We can talk about patient education tools. This is really something that I find really valuable, especially being in an environment where we manage patients who speak multiple languages. Now, this is something that, it could be you as your voice answering questions for patients in multiple languages. It's a little scary to think about your own personal avatar, but really something that can be very helpful. Now, when we think about development of a model, we really do have to clearly identify and clearly define
Tonight we're
inputs
good for
to the
tonight,
model, the intended use of the model,
Yeah, but I
and
just want to get it tonight.
ultimately the data and the performance that
Yeah.
supports that model. This is the background data, the background information that's there. So let's talk about this briefly and think about how these AI models are developed. Let's think about something like screening for glaucoma in a community environment. We can think about how that model is trained to distinguish between disease, glaucoma being present, and no disease, or the absence of disease. What are the distinguishing features? Really, this clinically comes down to the development or the inclusion of multiple data points. It's not just looking at the optic nerve, it's not just looking at intraocular pressure, it's putting these pieces together.
For the
So when
formula,
we really break down
the soap,
and
yeah,
look
Mrs.
at
Myers.
models that are being published in a research
For the
setting,
kids, yeah.
sometimes
But I
it's
can just
really
order it off of
difficult to
Amazon.
even find in how a model determined the presence or absence
No, I
of disease.
switched out of that one.
And sometimes, very disappointingly, it might be something as simple as a cup-to-disc ratio greater than 0.6.
When we come, we'll use
We
that
certainly
one.
all know in a clinical setting that just because someone has a vertical cup-to-disc ratio of 0.65, that doesn't mean the patient has disease. So there is a challenge in the validity in often the training data. Really, I think one of the important things as we're digging through this is to not just think about what a model is trained to do, but how it's trained to do it. Because as we are going to be marketed tools and technologies that we have to think about how we may apply them to our patient population, we really ultimately need to be the expert. Because again, we are ultimately responsible for this data. So can we trust it? Is it valid? Does it make sense from a clinical perspective? Now, back to screening. When we talk about screening, there always does need to be this prioritization of sensitivity or specificity. And truly within screening, specificity is the ultimate goal. We really do want to make sure that the people who get a referral to a provider are those who truly need it for that disease state. Now, of course, in a perfect setting, everyone will have access to care, will be able to see us for a comprehensive exam, but certainly we know this is not that perfect world. So when we think about screening, really we do want higher specificity than sensitivity. And what type of images are models trained on, or data as a whole? If we look at publicly available data sets, mostly they're from international populations that might fit very well into your patient population or not. This is the same sort of thought process in thinking about a reference database. How might the patient that you're using this tool or technology in be reflected in the types of images or patients that the model was trained on? These privately available data sets, sometimes these are even smaller subsets, again, from specific geographic locations, from specific university type settings. There's the introduction of these same types of challenges as our current reference databases. However, the one advantage here when we're talking about training data sets is that instead of talking about 600 eyes, we're often talking about 60,000 or 600,000. Now, if it's a broad range of information, there's probably more likely going to be someone in that data set that is reflective of your case. Or if it's a very narrow subset of patients, that might be very strong data, but very weak in reflection of your particular patient. So these images can be inherently biased, and that can impact how they work or how they perform in a real life clinical setting. We've talked site selection, subject selection, and really we need to think about these data sets being very well balanced, not just for patient age, patient background, patient features and demographic features, but also disease severity. Often, we think about the extreme end of disease, maybe those symptomatic patients that presented. What about those earlier cases, or what about those more middle ground cases that are often the more challenging to diagnose clinically? So we need a full spectrum of disease severity, not just the worst of the worst that are fairly straightforward to diagnose, but truly even the earliest disease cases to be able to detect that presence or help us to detect that presence of disease. Now, we do find, especially in these publicly available data sets, that There may be mislabeled data or missing data that absolutely can challenge the validity. And the methodology that's used to determine the presence of disease, again, can be number one, varied. Number two, not clinically reasonable or appropriate. Or number three, not specified at all, which is even more concerning. So this is something that our research group had investigated now a couple of years ago, was just to ask that question. The validity of publicly available data sets that are used by researchers around the world. Number one, are they clinically valid? Are the eyes that were determined in the data set to have glaucoma, do they actually have disease? What is that ground truth of presence or absence of disease? And we found that there was a large variety, that there were some publicly available data sets that truly performed very well as a very high quality data set. And there were others that generally were very poorly discriminative in an accurate clinical way of presence versus absence of glaucoma. The other thing that we thought about was, well, what other biomarkers may be valuable? This is something that we think about all the time clinically. What are our clinical biomarkers for presence of disease? And is there something that maybe we're not evaluating routinely now that maybe we should? And we were trying to evaluate vasculature. There's the connection here, of course, to OCT angiography, but this was much more simple, just creating vascular maps of the standard large retinal vessels to determine if we could develop a model that accurately detected the presence of glaucoma, not based on anything else other than these vascular maps. And unfortunately, the model didn't perform very well. From a clinical perspective, we were certainly able to differentiate actually better than our model was. They're not all successes. Maybe our limiting factor overall is image quality, which is an important real life consideration. Now, if we look at training data sets, where the data comes from, if we look at a center just very briefly, some centers will be able to have an opt-out program, meaning all of the patient's data can be utilized based on the forms that that patient signs for potential development of a model. Other large university centers have to have an opt-in system. NIST has decided at this point that retinal images are not biometric. We're showing retinal images. There is no way that you know who those patients are. However, someone can reverse engineer quite well to determine where that patient lives based on zip code, age, street, gender, not just biological sex, but gender. That was reported a number of years ago based on a fundus image alone. However, this is very challenging to do. It's been determined that retinal images are not considered biometric. So let's take a look at, really some of these differentiating features. What's another challenge that we have for those of us who work at multiple offices who may have different brands of technology at each office, even within the same group practice? What we know is that if we've got data based on one brand's OCT device, we can't directly apply that data to another brand of OCT. We've got the same patient imaged on two different brands of OCTs. The numbers will be very different. The overall printouts look quite different. Now, this is something that there are inherent differences in how these landmarks are detected. So this is truly another area for a potential AI model to really be practically helpful, to be able to translate from one brand of device to another. It really is like a translation service. When we have these training data sets, the models may perform very well in clinical trial settings, but in these wider populations, it really is something that sometimes the performance just doesn't match the same way. So how can we ensure that overall the models or the data that's utilized to develop a model are really high quality? And this is to include people that would otherwise be often traditionally excluded. Home-based options, having a tool or a piece of technology or an inclusion in a clinical trial being able to exist without that patient entering your office. That's an important thing to ensure that we're including our true population. And also international collaboration, which is something when we talk about sharing data and technology can be very challenging from a legal perspective, but something that is a real push to ensure that we have the highest quality of data that accurately reflects what we have as a global population. Now, another real important piece that we think about within glaucoma management, within sharing patients with one another, is how do we share data amongst ourselves as physicians from a clinical perspective? We call this interoperability. Now, when we're referring a patient for continuation of care. A patient just came back for her visit. She moved to Connecticut 6 months ago, and she's been flying back to South Florida for her visits. And, that's not reasonable. So get this patient set up with a colleague in Connecticut. And how am I sharing her past data? Unfortunately, as PDF images, static images of her OCT. Can the optometrist who is taking over care of her, can that optometrist actually use that data in PDF form? Absolutely not. We really do need to be able to share data in a meaningful way. Now, we talk about, and that certainly is possible. There's a standard that we call DICOM. We think about monitoring this patient over time. We look at the actual raw data that we can apply into our guided progression analysis. That's what it's all about, not just a printout, point A to point B, static images, but truly incorporating the images over time to truly watch for change. And I think this is something that is going to be a focus looking into the next 5 years. I truly do believe that there will be incentives for physicians to share data in these meaningful ways. The reason why is because of cost, and that could be related to insurance cost and out-of-pocket patient cost. How frustrating is it as a patient when they may be under your care and you are completely up to date with all imaging, and you transfer care, and 2 weeks later that patient sees another doctor and they repeat all of the imaging that patient has just paid for, and they're being charged for it. There needs to be some sort of incentive that we're able to truly, or that really pushes us to share data in a meaningful way. And that image file type is called DICOM. This does exist. So when you see DICOM in any of your imaging devices, this is the standardized imaging modality that stands for digital imaging and communications in medicine. We can transfer a DICOM file from one computer to another. If we're using the same brand of OCT, we can incorporate that data in our own progression analysis. It exists. It's not brand new. We are still behind on how we utilize this. Now, of course, there is a CPT code. We do have AI devices. There is a CPT code for imaging of the retina, for detection or monitoring of disease, and this is autonomous analysis. But if we think about how CMS really defines or really guides reimbursement, it's all about physician time. So if we're talking about incorporation of a device that autonomously images, analyzes, and develops a report, all tasks that would be done by a person, the analysis and report performed by the physician, this is a code that should reimburse really quite low, as the physician time is zero in this case. But if we're incorporating a new technology, that's new equipment, that's a new $50,000, $60,000, $100,000 upfront cost to the physician with a lower reimbursement based on current standards for reimbursement. So what this means is ultimately there is going to need to be an overhaul of how reimbursement is truly defined and thought about in the United States, something to, again, keep in mind and be aware of. Looking ahead, model transparency is truly very important, not just understanding what a model is supposed to do, but in my opinion, more importantly, what a model does not do. So if we're incorporating any tool or piece of equipment into our practice, whether it's AI-based or not right now, we think about it. What does it do? Really, What can it do, but what is it not designed to do? Where are the gaps? Where are the potential weak spots that I have to be aware of as a clinician? Wide field imaging, I bet almost every single one of us in this meeting tonight have some form of wide field imaging, an exceptional, wonderful tool. But at the same time, this images in a perfect setting 82% of the retina. That's the weak spot. A wonderful tool, but not 100% of the retina, not a replacement for our clinical examination, despite being an excellent tool. As we're moving into AI-based technologies, this is again the important piece for us to understand what a model is designed to do and developed to do, but what doesn't it do? And the way that I really think about this is addressing food labeling. So, you may go to the grocery store and there are two different, two different canned pasta sauces. And one, you're looking at them, you're comparing, they both look very good. How do you choose one versus another? I will tell you personally, I'm always going to choose the one, may not taste as good, but I'm going to choose the low sodium option based on my family history of cardiovascular disease, something to be aware of, right? How am I making that decision based on what I'm looking for from a personal perspective? When we think about choosing technologies, especially when we have choices, this is truly the same type of approach. We may be offered two different devices. How do we choose which one is best for our practice and our patients? There are new technologies that are moving forward that are truly exciting within the realm of AI and imaging. And when we really break it down, the way that we evaluate risk, the way that we detect disease, and ultimately the way that we manage disease in any state, specifically glaucoma, truly has changed and is continuing to change. The limitations of any technology are so important for us to know, understand, and truly appreciate, whether these are the technologies that we currently have in the office or those technologies that we're considering bringing into our office in the future. And as we think about what we do and the value of the clinician, these are truly tools to help us to make clinical decisions, and any piece of technology, current, past, present, is only as good as the clinician who's ultimately using it. So bottom line, the future, the present, 2025, it's an exciting time within our profession. I thank you for joining us. My information's here. If anything comes up, anything to discuss, any questions that you have tonight, looking ahead, I'm happy to serve as a resource. Maria, thank you once again for having me.
Thank you for a great lecture, and sorry everyone for that, glitch in the software. We're going to open it up to questions if anyone has any questions. And for those of you that do not have questions, you can sign off. You will get credit for the webinar for tonight. I will be sending out certificates in the next week or so and submitting to ABO as well. So I do not see any other questions here. Let's see here. All right, I think you did a great lecture, and we have no questions. So thank you, Dr. Steen, and thank you everyone for joining the webinar, and thank you for Virtual Field for the educational grant for tonight. Oh, one question here. Here we go. Oh, great lecture. Thank you for the lecture. Great lecture. So,
thank you all.
All right. Thank you, everyone. Bye-bye.